So, imagine going to a restaurant, right? You sit down and you order a nice 3-course meal.
Sounds great so far.
Yeah, you eat, you have a great time, and when you finally ask the waiter for the bill, he just kind of shrugs at you.
Wait, he just shrugs?
Yeah. He tells you, well, we don't actually know the price yet. We'll mail a mystery bill to your boss in about 3 weeks, and then, some third-party company is going to decide what you actually owe.
I mean, you would never accept that.
Right. You'd walk right out. Yet this is exactly how you interact with a massive $6 trillion industry every single day. We are talking about the U.S. healthcare delivery system.
It really is wild when you frame it like that.
It is, because you usually enter this system at your absolute most vulnerable moment, when you're sick or injured or just terrified.
Yeah.
And suddenly, all the normal rules of being a consumer just completely vanish.
Yeah, they go right out the window.
You buy blind, you have no idea who is really in charge, and the whole machinery operating around you just feels incredibly opaque.
It is entirely disorienting. And, what makes it so hard to grasp is that we keep calling it the U.S. healthcare system.
Right, with air quotes.
Exactly. Because it isn't actually a single system at all. It is a highly complex, intensely fragmented, and honestly kind of haphazard collection of independent actors. You've got all these financial interests and organizations operating in the same space.
But they aren't working together.
No, they are largely acting totally independently of one another, and they are driven by entirely different motives.
Which is exactly why we need to unpack this today. We were taking a deep dive into the source material, specifically some really foundational chapters on health policy.
It's some dense stuff, but so important.
Very dense, yeah. But our mission here is to map out this hidden machinery. We want to figure out who is actually pulling the financial strings and really give you the ultimate cheat sheet to being an empowered consumer of your own care.
I love that.
Because whether you are perfectly healthy right now or you're managing a chronic illness, this sector, it touches every single one of us.
It absolutely does. And the sheer gravity of it is rooted in something deeply philosophical, actually.
Oh, really? How so?
Well, if we trace the foundation of American healthcare all the way back, we land on the Declaration of Independence.
Wait, all the way back to the Declaration?
Yeah, because that document guarantees the pursuit of life. And that single, powerful, aspiration-preserving and extending human life is essentially the philosophical engine fueling this entire sector.
Wow. And I mean, what a massive engine it is. If you're trying to wrap your head around the scale of this industry, just think about this. Healthcare commands almost 20% of the entire U.S. gross domestic product.
That is just a staggering number.
It is. And the projections have it hitting $6 trillion by 2028. $6 trillion.
Yeah.
Plus, it employs a full 11% of the American workforce. That means more than 1 in 10 people you pass on the street are working in some capacity to keep this behemoth moving.
Right. And with a footprint that massive, you inevitably run into a really profound, uniquely American tension.
You mean the whole free market debate?
Exactly. It's the ideological tug-of-war between the free market and government control.
Right.
Are medical services simply a consumer good, subject to the ruthless forces of supply and demand? Or is healthcare a fundamental human right that a society owes to its citizens?
And we've never really answered that, have we?
No, we haven't, because society has never fully agreed on the answer. The architecture of how we actually deliver care was never centrally designed.
It evolved in a total vacuum of a master plan.
Pretty much, yeah.
As I was digging through our sources on how fragmented it all is, I kept picturing this analogy. It's sort of like trying to build a massive state-of-the-art mansion by hiring 100 different contractors.
Okay, I can see where this is going.
Right, so you drop the electricians, the plumbers, the carpenters, all on a work site. You give them top-tier tools, but you legally forbid them from talking to each other or looking at the exact same blueprint.
That sounds like a disaster.
It is. You're going to end up with some incredibly gorgeous individual rooms, but the hallways aren't going to connect. The stairs will lead to nowhere, and the plumbing is just going to be an absolute mess.
That is a remarkably accurate visualization, actually. And, it happened that way because those contractors weren't following a blueprint. They were following the money.
Following the money.
Always. And they were chasing rapid 20th century technological booms. So you had the sudden development of vaccines, advanced imaging technology, complex surgeries. It all happened so fast.
So the infrastructure just kind of grew around the new toys.
Exactly. It haphazardly grew around whatever was most profitable to do at the time.
So if this haphazard mansion was built by economic incentives, we really need to look at how those incentives work. Or, I guess rather, why they are so completely broken.
Yeah, that brings us to the beating heart of the dysfunction of the fee-for-service payment model.
Okay, break that down for us. What is fee-for-service?
Sure, so in a traditional fee-for-service setup, a healthcare provider is rewarded financially based on the sheer volume of billable services they perform.
Volume, not quality.
Right, volume. They get paid for every individual test ordered, every scan done, every procedure completed. What they are not inherently paid for is the value, the efficiency, or the actual long-term outcome of that care.
Let me stop you right there. Because that essentially implies that doctors get paid for doing things to you, not for keeping you healthy.
That is the uncomfortable reality of the financial model.
Ow.
It creates an economic logic where treating a highly complex, severe illness is vastly more profitable than preventing that illness in the first place.
That feels completely backward.
It is, and if you really want to understand how entrenched this is, you have to look at the 5 major power players, the stakeholders, who are just constantly warring over this massive pool of money.
Okay, let's go through them. Who is player number 1?
The first stakeholder, who theoretically should be the most important, is the consumer, you.
But wait, earlier we talked about the restaurant bill. In what other industry does the primary consumer have zero leverage?
Pretty much nowhere else.
The patient usually has absolutely no idea what a medical service costs until weeks after they've recovered. Sometimes you never see the real price.
No, you really don't.
The hospital doesn't even view you as the one paying the bill. They're looking right past you, directly at your insurance company.
It is a profound disconnect, and it leaves the consumer as a mere bystander, which brings us to the second and third stakeholders, providers and employers.
Okay, providers make sense. That's the doctors, the nurses, the hospitals.
Right, and they are increasingly abandoning small private practices and consolidating into massive corporate groups.
Why is that? Just for more power?
Mostly because they are drowning in the administrative burden of just trying to get paid by dozens of different insurance plans. They simply want fair compensation for their immense training without all the red tape.
Makes sense. But what about employers? Why are they considered a major stakeholder if they aren't treating anyone?
Because in America, employers bear a massive portion of the cost of doing business by providing health insurance to their workers.
Oh, right. It's a huge expense for them.
A massive hit to their bottom line. So their goal is very straightforward. They want healthy, productive workers, and they desperately want lower premium costs.
Which leaves us with the last 2 players, insurers and public policy makers. Now, insurers are basically the referees taking the financial risk, right?
That's the theory, yes.
But wait, if an insurer's on the hook to pay the hospital when I get sick, shouldn't their primary goal be to lower costs and keep me out of the hospital?
You would think so, but the reality is way more complicated. Insurers absolutely want to manage risk, but they are also highly incentivized to protect their lucrative role as the middleman.
Because if costs drop, their cut drops.
Exactly. If the total cost of healthcare were to miraculously plummet, their premium revenues and their overall profit margins would shrink right along with it. They want predictable costs, but they also want to maintain their massive footprint in the industry.
That is a wild conflict of interest.
It really is. And finally, you have the public policymakers who are trying to regulate this entire chaotic dance while still fundamentally disagreeing on that free market good versus human right debate we talked about.
So every single one of these stakeholders is pulling in a different direction. Employers want cheap premiums, insurers want middleman profits, providers want maximum reimbursement for their time, and you, the consumer, are just trying to get better without going bankrupt.
That perfectly sums up the gridlock.
So if these are the financial forces pulling the strings, let's look at what they're actually buying. Let's walk through the actual menu of services, from the absolute simplest preventative steps to the most extreme medical interventions on Earth.
Good idea. And it all starts with prevention.
Right. And breaking down the levels of prevention is crucial because it shows us where the money should be going versus where it actually goes.
Exactly.
I found the easiest way to visualize this care continuum, reading through the sources, is to think about car maintenance.
Oh, I like this analogy. Let's hear it.
So primary prevention is like getting regular oil changes. Your car is running perfectly fine, but you're doing basic, inexpensive things to stop problems before they ever start.
Right.
In the medical world, this is giving a child a polio vaccine, doing well baby checkups, and yes, even just basic public health campaigns about washing your hands.
Which, by the way, is incredibly effective and cheap. But when primary prevention fails or is skipped entirely, we move to secondary prevention.
Right. Secondary prevention is when the check engine light flickers on and you plug a diagnostic reader into the dashboard to figure out what's wrong before the engine blows.
Early detection.
Exactly. Clinically, this is all about early detection. We're talking routine colonoscopies, mammograms, or blood pressure screenings. The disease might already be quietly starting, but you are trying to catch it early enough to completely cure or control it.
And if that window is missed, unfortunately, you land in tertiary prevention.
Yeah, tertiary prevention is basically pulling over on the highway and frantically trying to cool the engine down after it's already overheated just to stop the whole car from completely exploding.
It's all about damage control at that point.
The disease is established, the symptoms are obvious, and the entire goal is just preventing permanent disability or catastrophic complications. Like teaching a patient with advanced diabetes how to aggressively manage foot wounds so they don't end up requiring an amputation.
And that tertiary level, that is where the system is currently buckling.
Because it's so expensive.
Extremely. If you look at where the money flows, 71 cents of every single healthcare dollar spent in this country goes to treating people with multiple chronic conditions.
Wait, 71 cents of every dollar? That is wild.
It is, because managing chronic disease isn't just a one-time surgical fix. It involves a massive, continuous logistical effort.
Like what?
It's coordinating multiple specialists, paying for decades of expensive prescription medications, and dealing with the inevitable, highly costly trips to the emergency room when the condition flares up. The slow burn of chronic disease is the heavy lifting of the entire medical system.
That alone shows why those oil changes, the primary and secondary prevention, are so economically vital.
Absolutely.
But obviously, even with perfect maintenance, sometimes a car just gets T-boned in an intersection.
Right.
Emergencies happen, and that drops us right into acute care.
Yes. This is where the machinery of the hospital gets incredibly structured.
It has to be, right?
It does. The emergency department is a fascinating environment because it has to bring pure, cold logic into a space that is usually filled with human panic. When you walk into an ER, your treatment order isn't based on a first-come, first-served line.
Thank goodness.
Right. It's dictated by a highly sophisticated triage algorithm called the Emergency Severity Index, or ESI.
And how exactly does a triage nurse make that split-second decision when there are like 30 angry people sitting in a waiting room?
It's a 5-level stratification system, and the beauty of it is how it overrides subjective human emotion. A triage nurse isn't just looking at who is complaining the loudest.
So what's level 1?
Level 1 is immediate. This is the patient whose heart has stopped or who's actively bleeding out. They require a doctor in less than 1 minute.
Okay, that makes sense.
Then level 2 is emergent, meaning they need to be seen within 14 minutes.
Oh.
Think of a stroke patient where every minute means millions of brain cells are dying, or someone having a heart attack who might just be sitting quietly in the corner sweating.
Oh, wow. So the quiet patient sweating might be a level 2, bypassing the screaming patient with a broken arm?
Exactly. The algorithm protects the quiet, critical patient. Then you move down. Level 3 is urgent, where you can safely wait up to an hour. Level 4 is semi-urgent, and level 5 is non-urgent, which honestly could safely wait up to 24 hours because it just requires a basic exam without any complex x-rays or lab work. The ESI is a logistical masterpiece designed to distribute limited resources to save the most critical lives first.
And there is a massive legal safety net operating in that waiting room too, right?
Yeah.
Because we've all heard those horror stories of people worrying about being turned away if they don't have insurance.
Right. But there is a strict law against that.
EMTALA, right. The Emergency Medical Treatment and Labor Act. Our sources talk about how it mandates that anyone presenting at an ER must be screened, evaluated, and stabilized entirely regardless of their ability to pay.
It's a fundamental protection.
But the really brilliant part of this law that I read was how it legally defines an emergency using what's called the prudent layperson standard.
Yes, this is one of the most important legal protections a consumer has.
Break that down for us. What is a prudent layperson?
It means that if a regular, prudent person with average medical knowledge experiences symptoms severe enough that they reasonably believe their life or limb is in jeopardy, the hospital is legally required to treat it as an emergency.
So it's based on the patient's reasonable fear, not a doctor's final diagnosis.
Exactly. If you wake up with crushing chest pain and arm numbness and you rush to the ER terrified you're having a heart attack, they have to evaluate and stabilize you.
Even if it's just heartburn.
Even if it turns out 3 hours later that it was just a severe case of heartburn. Your insurance can't refuse to cover the ER visit after the fact, and the hospital can't turn you away. It protects your right to seek emergency care based on a reasonable human fear, rather than requiring you to possess a medical degree before you walk through the doors.
That makes total sense. Now, once you are stabilized and actually admitted to the hospital, you move up the continuum to higher levels of care. There is tertiary care, which is highly specialized, complex work.
Like a coronary bypass surgery or spending weeks in a severe burn unit.
Right. But then there's a tier even above that, quaternary care. What elevates something to quaternary?
Quaternary care is the absolute bleeding edge of modern medicine. It's an extension of tertiary care, but it involves highly experimental medicine, incredibly rare surgeries, or complex organ transplants.
So not something my local clinic is doing.
Definitely not. You are not going to find quaternary care at your local neighborhood hospital. You have to travel to a major specialized academic medical center to receive it.
And finally, at the very end of the care continuum, there is hospice.
Yes, end-of-life care.
This is specifically utilized when a patient is clinically expected to live 6 months or less, right? The entire philosophy of care shifts here. The goal is no longer to cure the underlying disease.
Right. The focus changes entirely.
It transitions to palliative care, managing pain, ensuring comfort, and providing deep emotional and spiritual support for both the patient and their family.
And, what we are seeing now is a massive push by public health leaders to look at this entire continuum and realize we can't just wait for people to arrive at the hospital doors.
We have to go to them.
Exactly. There is a growing focus on population health. Instead of just treating the individual asthmatic who shows up in the ER as an ESI level 2, health systems are analyzing community data to manage entire groups of people.
Oh, like a proactive approach?
Yes. They want to ensure all the asthmatics in a specific zip code have inhalers in clean air environments, keeping them healthy before they ever need to trigger that emergency machinery.
Okay, so we've covered the broken financial incentives, and we understand the menu of care from hand washing all the way up to experimental organ transplants. But where does all this physically happen?
In the hospitals, mostly.
Right, but the landscape of hospitals in the U.S. is deeply divided. Our sources note there are roughly 6,090 registered hospitals in the country.
And the vast majority of them, around 84%, are community hospitals. These are the short-term general hospitals accessible to the general public.
But if you look at who actually owns these buildings, you uncover a real cultural clash in American medicine.
You do. It's a huge divide.
So 57% of these community hospitals are voluntary, nonprofit organizations. Because the government views them as charities providing a public good, they're tax exempt.
Right.
They don't pay federal income or property taxes.
Correct.
And historically, they have a very service-driven, community-first culture, often tied to religious or community groups.
Conversely, roughly 24% of hospitals are investor-owned, for-profit institutions.
Meaning they have shareholders.
Exactly. These
Yeah.
are owned by private companies or shareholders. They absolutely pay taxes, and they operate under a strict dual mandate. They must deliver clinical care, sure, but they also have a fiduciary duty to generate a financial return on investment for their shareholders.
Which naturally fosters a much more business-driven, efficiency-focused culture.
Yeah.
But let me challenge that for a second. If I'm lying on our operating table having my appendix removed, the surgeon's scalpel is exactly the same, whether I'm in a tax-exempt nonprofit building or a shareholder-owned for-profit building. My anatomy doesn't change.
It does not.
So does the culture of the boardroom actually impact the care I receive?
The scalpel doesn't change, no, but the environment holding the scalpel absolutely does.
Oh, so?
Because the boardroom decides the hospital's resource allocation. They decide how many nurses are staffed on your recovery floor, which directly impacts how closely you are monitored.
Oh, wow.
They decide whether to invest in the latest robotic surgery tech or cut back on less profitable services like psychiatric care. The business model dictates the entire infrastructure surrounding your surgeon.
That makes a lot of sense. So how do we fix that?
Well, the modern attempt to fix the flaws in both models and to fix our haphazard mansion analogy from earlier is the rise of integrated delivery systems, or IDSs.
An integrated delivery system. So this is like forcing all those mansion contractors into a single group chat.
Exactly. An IDS is a collaborative network where hospitals, primary care clinics, specialists, and sometimes even the insurance plans themselves consolidate into one unified network.
So they are finally on the same team.
They share financial responsibility, but crucially, they share data. Research consistently shows that when you integrate these pieces, quality goes up and costs go down.
Because suddenly, Everyone is looking at the same blueprint.
Precisely. The primary care doctor can instantly see the notes from your ER visit, which means they don't order a duplicate, expensive MRI.
So integration is sort of the holy grail. But man, even with these IDS networks popping up, the U.S. healthcare system is buckling under the weight of several overarching crises.
It really is.
It's like a roof that is leaking in 7 different places at once.
Hmm.
Reading the source material, they identify 7 overarching themes needing improvement.
These are the systemic stress tests. First, there's the ongoing crisis of quality. Despite having the most advanced technology on Earth, frequent and totally avoidable medical errors still happen.
Second is access and coverage. Third is the desperate need to slow down the explosive, unsustainable growth of healthcare expenditures.
Fourth is the struggle to encourage healthy lifestyle behaviors in the broader population.
Fifth is the need to improve our underlying public health infrastructure. Sixth is coordination and transparency, getting rid of that blind buying restaurant experience so patients actually know what things cost.
And the seventh is a glaring one, addressing stark inequalities in care that are entirely based on a patient's income, their race, or their geographic location.
And speaking of access and coverage, we have to talk about the Affordable Care Act.
Yes, the ACA.
Now, just to be super clear with our listeners here, we're just neutrally reporting the textbook's factual assessment of the landscape here. We aren't taking any political side.
Absolutely, just sticking to what the source material states. The text notes that when the ACA rolled out, there was a dramatic factual drop in the number of Americans living without health insurance.
But because healthcare policy is so intensely polarized, several states opted out of expanding Medicaid coverage for their low-income residents.
Right, and this created a fractured patchwork where your access to life-saving care heavily depends on which side of a state border you happen to live on.
And compounding all of these leaks in the roof is a massive, unavoidable demographic shift. The U.S. population is rapidly aging.
The baby boomer generation.
Exactly. They are moving into their later years, which means in the next decade, there is going to be immense, unprecedented pressure placed on long-term care facilities and public programs like Medicare.
And, as if those slow-moving crises weren't enough, we recently lived through the ultimate catastrophic stress test, the COVID-19 pandemic.
Oh, absolutely.
It completely overwhelmed the physical clinical delivery system. But more profoundly, it highlighted an incredible paradox in American healthcare.
What paradox?
While on one hand, we witnessed unbelievable scientific and technological triumphs, like the rapid sequencing of the virus and the development of mRNA vaccines.
Miracles of modern science, really.
But on the other hand, the pandemic revealed a devastating, systemic lack of public trust in health advice, science, and medical institutions.
So if you're trying to navigate this system today, what does this all mean for you? You're living in a world with miracle vaccines, but broken trust. High-tech surgery, but blind pricing.
It's a lot to process.
It is. But honestly, the most eye-opening insight from our sources is that the system's biggest blind spots are actually what we call the social determinants of health.
Yes, this is perhaps the most crucial concept we can discuss today. The social determinants of health mean that your longevity and your physical well-being are actually dictated far more by your social and economic circumstances than by the actual medical care you receive in a clinic.
Wait, really? More than the actual medicine?
Much more. It's about whether you have an adequate family income, access to high-quality education, strong social support connections, and safe, stable housing.
Put simply, your zip code is often a much better predictor of your health and lifespan than your genetic code or the Ivy League pedigree of your doctor.
Which brings us to the concept of community benefit. If the social determinants of health are the true drivers of human life, then we need a totally new generation of adaptable health leaders.
We need thinkers who can operate outside the traditional fee-for-service mindset.
Exactly. Leaders who recognize that investing in a community's reliable food supply or removing lead paint from affordable housing is just as much a valid medical intervention as buying a new MRI machine.
Okay, let's bring it all home. We've covered an immense amount of ground today. We started by mapping out a $6 trillion behemoth that evolved without a master blueprint, fueled by the philosophical right to life.
We unpacked the deeply flawed financial incentives of the fee-for-service model, where volume trumps value, and we saw how consumers are left completely in the dark on pricing.
We followed the care continuum, from the cheap, effective primary prevention of hand washing, all the way up to the quaternary extremes of experimental transplants.
We broke down the logistical brilliance of ER triage, explored the cultural boardroom divide between nonprofit and for-profit hospitals, and looked at how the pandemic served as the ultimate stress test for our fragmented infrastructure.
It is a system built on incredible, sometimes maddening contradictions. But I want to leave you with a thought that builds on those social determinants of health we just touched on.
It's an important question to ask.
Right now, we are spending almost 20% of our GDP, $6 trillion. And the vast majority of that goes toward treating sickness after it has already happened. But if our health is actually determined more by social factors like our zip code, our education, and our housing, than by the medical care we receive, what would happen if we fundamentally shifted the money?
That is the question.
What if we took a massive chunk of that $6 trillion medical budget and spent it entirely outside the hospital walls?
It's a fascinating paradigm shift. What would a true health in all society look like, where stable housing, good schools, and clean environments are treated and funded as the ultimate medical interventions? It changes how we view the value of every single dollar spent.
Something for you to mull over as you navigate your own corner of this wild, haphazard mansion we call a healthcare system. Never stop questioning the blueprint. Keep pushing for transparency and keep looking for how it all connects. Thanks for joining us on this deep dive into the source material.